for having me here. So at the outset, honest thanks to the organizers for this session today, and thank you, Vidita, for the kind introduction. I think what I have is a slightly tricky topic today, because we are not just talking about cardiometabolic disorders, but the cardiometabolic complications as well. The speakers before me have justified it beautifully about the interplay of the different aspects of cardiometabolic disorder. This is the slide for history that was asked of us, and all credit goes to AI for that. What we would do today is, I'll take you through what cardiometabolic disorders are and how are they related from a nutritional perspective, outline the nutritional interventions and the foundational concepts that we have, talk about what is being discussed today, and hopefully come up with a holistic approach to address the same. So cardiometabolic disorders, as all of us are aware, they encompass a cluster of interconnected conditions, be it obesity, type 2 diabetes, hypertension, dyslipidemia, and of course cancer also. But today we would not be talking about cancer much. We'll be looking at more of the obesity and the metabolic syndrome that we are looking at. The role, I would say, starts not just in managing these diseases, but as prevention as well. The dietary risk factors have become one of the leading causes for metabolic disorders today. The cardiovascular mortality has shot up drastically in the past few years, and I think it was about 15, 17 years back where dietary risk factors stood somewhere around, somewhere at the 7th highest risk factors for cardiometabolic disorders, and today they are one of the leading disorders, especially in a South Asian population. And hence, I think it's extremely important to look at these risk factors in totality. The nutritional interventions, I think someone has very rightly talked about the DASH diet and the Mediterranean diet, or be it a plant-based diet. It goes unsaid that we do need to look at behavioral modifications and not just the advice that we give that you need to follow a DASH diet or you need to follow a Mediterranean diet. What is Indianized, what is not just Indianized, I'll say what is more regional matters. I think this is one of those few conferences where I've seen a Jain food layout as well. Now, if you go to any other conference, let's say if you go to Delhi, if you go to Maharashtra, very rarely will you have a Jain outlet there, right? So that talks about the variety and diversity that we have. And until and unless we are in tune with the regional requirements, it becomes extremely difficult to plan a nutritional or a comprehensive nutritional plan for the patient. To understand cardiometabolic risk, it's again important that we start linking the metabolic syndrome, because ultimately, with all of these in place, it boils down to giving just one diet plan. You cannot say that, all right, you have diabetes and you have obesity, so this is the plan for diabetes and this is the plan for obesity. We will need to integrate the whole thing. Starting with hypertension, which is very close to my heart. So hypertension will stem from hyperinsulinemia as well. We are looking at insulin resistance, which leads to an increased sodium absorption by the kidneys. We do call it the hungry kidney syndrome, and that does trigger a volume expansion. Now, in normal conditions, the volume expansion will downregulate the renal insulin receptors, which will restore the normal volume status, and therefore you really do not have a person landing up in hypertension in those cases. But when you have a patient who's already susceptible or at risk, this downregulation is not as active. This does lead us to an atherosclerotic disease as well. So the development of ASCVD is a consequence of long-standing dyslipidemia, hypertension, and inflammation, which again is a milieu of risk factors that we are talking about. Often ignored is the peripheral artery disease. Most cases, I think even a screening for a PAD is not done, and that is sad because until and unless we have an early management of risk factors for PAD, the outcomes are absolutely deleterious for the patient. That gets us to dyslipidemia and the elevated triglycerides, where the cholesterol efflux in the liver goes down and the triglyceride levels and the VLDC levels are higher. And therefore, what we do see is there's a reduction in the HDLC concentrations and a reduction in the triglyceride content in the LDL itself. In addition, the hepatic lipase will remove the triglycerides and phospholipids from the LDL for the final formation of triglyceride depleted small dense LDL, which is all the more deleterious for the whole of the vascular system and the heart. Insulin resistance is much talked about. I will not delve deeper into this, but we do need to remember that there is a domino effect that happens. So you have lipodystrophy, you have lipotoxicity or oxidative stress, we have glucotoxicity or genetic susceptibilities along with the hormonal disbalances leading to insulin resistance, and that basically triggers an array of diseases. Each person may land up in a different set of these diseases, be it myocardial infarcts or chronic kidney diseases or fatty liver or even a very chronic inflammatory state. And therefore the initial insulin resistance is what we should be able to identify. Now, obesity is always and always talked about, and central adiposity, as Shilpa had also mentioned very clearly, that if you're looking at central adiposity, you need to address it. You do not need to wait for anything else to start developing. And in an obese state, you will see that the anti-inflammatory adipose tissue, and there's a disbalance between the anti-inflammatory and the pro-inflammatory macrophages as well. And the insulin sensitizing adipokines and the anti-inflammatory properties such as adiponectin again become decreased when we are looking at a chronic obese state. Now, what will happen is the adiponectin levels have gone down, the inflammatory state is higher, there's higher dyslipidemia, insulin resistance. We are looking at NAFLD, and not just NAFLD, we are looking at MASLD today. The pro-inflammatory adipokines will also start going up. We have all the cytokines and the pro-inflammatory markers rising in the body. So the visceral adipose tissue will become, the higher the visceral adipose tissue, higher are the chances for complications. There will be higher systemic inflammation that we are looking at. And of course, the long-term inflammation will lead to endothelial dysfunction as well. So adiposity becomes one of the major risk factors and triggers for MASLD. So MASLD is a condition where we are looking at liver dysfunction, which is derived from metabolic disorders. So it's not just alcoholic liver diseases or non-alcoholic liver diseases. So MASLD is a condition which we will see even in lean patients. So with MASLD and systemic inflammation, we do see that there is more accumulation of fat in the liver, and the compounding effects of these conditions will increase the danger of atherosclerotic cardiovascular diseases, and of course, prevention is the key. The importance is in addressing the risk factors, and that gets us to how do we address these risk factors. I think we have already seen the calculations, we've seen the percentages that we need to focus on carbohydrates, proteins, healthier fat options. There are multiple guidelines, be it the AHA guidelines or the ISH guidelines, which say that you need to switch the fats, you need to switch to complex carbohydrates. But the point is, will this all really lead in weight reduction? Do we need to go beyond and talk about caloric restriction for a longer duration of time? And what are the quantifiable results that we are looking at? Are we just looking at weight loss? We are looking at body composition changes. And are these actually enough? I think that is where the bottom line is. When we talk about Mediterranean diets, when we talk about DASH diet, or even a plant-based approach, how good is the adherence? That is a question that has come up multiple times. So one, adherence, and the other is compliance. So I think that is one question someone did come up with, was about intermittent fasting. So as Shilpa said, intermittent fasting is a type of calorie restricted eating. Now within calorie restricted eating, you could have alternate day caloric restriction, or a daily caloric restriction, where you're looking at only 30% reduction of the total calories that the person was already consuming. Or you have an alternate day fasting, where you have a 24-hour fasting window and then again 24 hours of eating. Or a time restricted, which is typically called as intermittent fasting, which depends, it could be 8 hours of eating and 16 hours of fasting, or you have 14 and 10 hours, so depending on what works for the patient. But that is the key sentence, I'd say: what works for your patient. There are multiple studies which say that 5:2 intermittent fasting, where a person eats for 5 days and fasts for 2 days a week, compared to a daily caloric restriction, will give you almost similar results on a longer duration of time. That is almost for a year of, a year-long study. When that was done, that is what was found. Now, when we do caloric restriction or intermittent fasting or alternate day fasting, these are the benefits you see. So red indicates caloric restriction, orange is intermittent fasting, and green is alternate day fasting. So honestly, if you see the maximum benefits, you don't even have to read what it is, but the maximum benefits are for daily caloric restriction. But what is important is, what are the risk factors and what are the cardiometabolic complications that your patient suffers from. Now, if your patient is suffering more, let's say, has predominantly hypertension, though in those cases, probably an alternate day fasting works better. But caloric restriction is way more easier to sustain. It is even for a long term, if you ask a patient to have caloric restriction, it's easier to incorporate into a daily diet, because you're just asking them to reduce by 25 to 30% of daily calories on a day, in all. Now, micronutrients, again, we have the key micronutrients. Everyone has listed them out, be it vitamin B, B12, methionine, as Shivasa said, or polyphenols, or vitamin D, B12. All of these things, again, extensively spoken about. That also means, when we are speaking about these, most of these patients would by and large land up taking supplements, either prescribed or unprescribed, unfortunately. But yes, a lot of them will get themselves tested and will start on off supplements. My question is, do we go beyond it? Do we consider any other nutrients that can be included? So yes, fiber and prebiotics, probiotics become a major part when we're talking about the different types of carbohydrates. But beyond that, restrictions is something that we need to start with, which is sodium and alcohol restriction needs to be there. Alcohol is something, unfortunately, I'd say there's so much of talk about resveratrol and, the type of alcohol to be consumed, and red wine being healthy. We'll come to that as well. So if we go beyond the micronutrients, there are a few other nutrients as well which are extremely helpful, which is spermidine, resveratrol, and NAD precursors. Spermidine will have anti-inflammatory effects, and it increases the visceral fat lipolysis. It is it works on the mechanism of autophagy, and therefore it is extremely helpful. But again, the human evidence is low. It is found in wheat germs, soy, nuts, and it's pretty rich in the Mediterranean diet. The resveratrol is where the question comes in, because of its anti-inflammatory effects, and I think the French paradox as well. Now, the point is, how much resveratrol is there in red wine? Now, resveratrol is there in the skin of grapes. Red wine is not made only from the skin, the grapes are also used. If you look at the different types of wines, this is the amount of resveratrol that is present. And the minimum daily dose that is required for resveratrol is 150 milligrams per day. So I mean, I guess 5 milligrams of poignanoid gives you, 1 liter gives you about 5 milligrams. So to get 150 milligrams per day, I'm not sure if you need to even eat anything. You'll probably just drink the whole day. And that's where the science comes in. NAD precursors, again, will help in reduction of blood pressure and improve the diastolic dysfunction. The mechanisms, again, are to preserve the cardiac function. Metformin, I think, a very august gathering here, so I'm not going into the details of that. So the practical strategies are, let's look at personalization, let's look at evidence, let's look at regular monitoring, and identify the barriers that your patient has. Try and introduce gradual adjustments. Talk about education and support, both for the patients. We need to identify these barriers at a personal, interpersonal, environmental, organizational, and policy-related levels. So, honestly, if we go out in the market, if you are short on cash, I'm not sure if you'll go and buy an apple or you'll buy a loaf of bread. So that is where policy becomes important as well. So let's maintain a long-term adherence and have a more broader perspective with a holistic approach to integrate exercise, because that does have synergistic effects. And let's look at stress management as well. So our key takeaways are, we need to look at nutritional management, which is customized and holistic. Thank you.